Hello, welcome to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Each episode, we bring you a conversation with leaders across the healthcare industry, exploring topics ranging from new treatment techniques and interventions to novel service delivery methods and business models. And now your host, Rafi Salazar from Rehab Practice Solutions, a leader in patient engagement and retention strategy. Let's explore the possibilities of a new healthcare.
Hey everybody, welcome back to another episode of the Better Outcomes Show. My guest this week is exciting to talk about. So this week we're going to discuss direct primary care and all that whole concept entails. If you're anything like me, even somebody in the healthcare space and treating patients and referring patients and just being in the ins and outs of healthcare, there's often some misconceptions and questions about what is direct primary care, how does it work, all of that sort of thing. So my guest this week is Dr. Rob Lamberts from Augusta, Georgia, and he is a direct primary care physician. He's also helped a few other practices in our local market start up. So he's a wealth of knowledge when it comes to direct primary care, how to get the business of healthcare and the patient's best interest aligned. So working on incentives and pricing models and structure and increasing access and decreasing cost, while at the same time improving the interaction between the physician, in this case, and the client or the patient. So hopefully you pull a good bit away from this episode or this interview. Again, without further ado, here's Dr. Rob Lamberts talking about direct primary care. Well, Dr. Rob, thanks for being on the show. How are you doing?
I'm doing great, Rafi.
Awesome. Before we get started, why don't you tell us all a little bit about yourself, your professional background, and kind of how you came to be into the whole direct primary care space?
Yeah, well, I've been a physician here in Augusta since 1994. Actually did my medical school in Philadelphia at Jefferson, and then went to Indiana to do my residency, which is in internal medicine and pediatrics. I was board certified. I'm board certified in both of those specialties. So it's basically primary care, kind of a
like a family care almost, right?
Family medicine on steroids in some ways,
Yeah.
because I got the double board certification that just allows me to go a little more in depth on the two sides that interested me the most of primary care. I came to Augusta in '94 and have been in primary care practice the whole time. I was a member of a classic fee-for-service insurance-based practice for 18 years, and through a lot of circumstances, just differences of practice style, other things just didn't work out between me and the partners of the practice that I was in. And so decided to go our separate ways. And as I was looking at the practice options, my focus when I was in practice in the other practice was a patient-centered care, just basically frustrated with the fact that the healthcare system was forcing me to choose between what was best for the business of medicine for me, which was to see as many patients as possible, to spend as little time with them as possible, to have people as sick as possible, to bring people in for the whatever reason, whether it was
as many tests as you could bill as possible, right?
Exactly. So doing all of those types of things and racking up the care, but not really care. I began to feel like I was spending so much time doing that. And then there's the whole documentation side of thing that now dominates healthcare, that it just felt like I was despite having over 2,000 patients, I was not really able to give any of them good care. And so I was looking for a different model. I wasn't just wanting to go back to what I was doing. And I stumbled upon direct primary care, which is, it's not really a new model per se, but it's a new take on an old model.
Yeah. So why don't you kind of explain for somebody that doesn't know what is, when we say direct primary care, what do we mean by that today?
Yeah, people often say, well, is that the same as concierge medicine? Because they've heard about concierge,
Yeah.
which is usually a higher end, higher cost healthcare. And rich people sign up and they pay a lot of doctors and they get a lot of money
They get
per
access to
month.
them,
And they get
that sort of thing.
access to the doctor anytime they want and get extra special care. It's kind of like riding first class. And this is different than that for several reasons. First off is the cost is a lot lower. Direct primary care averages under $100 a month, and my average cost is more toward $50, between $50 and $60 per month, depending on the age of the patient. As low as $35 per month, actually.
Oh, wow.
Yeah, and then the other difference is that as opposed to concierge care, will a lot of times still bill insurance, and then they'll do for uninsurable, there's a part that insurance doesn't pay for that they're able to do a fee for, a monthly fee or something like that. In direct primary care, you basically get rid of all insurance. You don't want the patient to get rid of insurance, but in terms of the care that you're giving, that I'm giving, my patients pay me for it once a month and that's it. And it has nothing, I don't accept money from insurance companies. We'll work with insurance companies to make sure the patient gets the specialty care that they need, the hospital care that they need, or the procedures and that type of stuff. But in terms of paying primary care, which is really, it's kind of silly that it's insured anyway, because it's not expensive.
Yeah.
There's nothing that I can do that'll rack up $1,000 bill as a primary care doctor, as opposed to specialists where
like an orthopedic surgeon or something like that.
Yeah, you can go through $20,000 with the hospital, with just one procedure. I'd say it's a lot like auto insurance covering gas in your car or oil changes or tires. Why do we do that? Well, we don't do that because it's just not expensive enough. So I'm paid by my patients, and instead of being paid per visit, I'm paid once a month, and that's it. I don't charge beyond that. So the two central things are the monthly payment and the being paid by the patients directly.
Yeah.
Right.
Okay. So kind of this concierge model that you described earlier, it's kind of above and beyond. The doctor's still billing insurance, and then they're doing extra stuff that their insurance won't pay for. So then they're just tacking on a fee.
Exactly.
And when it comes to you, you're kind of getting they're paying a flat rate, and that gives them access to you, and you're doing primary services, but you're not billing any insurance.
Right.
Okay.
And people will say, so what keeps people from coming in 10
50
times
in a month? Yeah.
50, yeah. Well, first off, it's a doctor's office. Why would you go to the doctor's office that often? I mean,
yeah, we're trying to stay out of there.
If somebody said I could go to the dentist, 50 times a month, I would say, well, gosh, thanks a lot. I'm still not going to go. It's not. It takes a special kind of crazy to go to the doctor that often. I think the key is that when we do that, when we separate the care from the payment, in other words, we separate the volume of care from the payment, then what it does is it enables us to do remote care. It enables patients to send us text messages and ask us questions. It enables patients us to do phone call medicine or video visits. It enables us to not worry about how it's going to get paid. And then if we say, well, for example, a woman has typical urinary tract infection symptoms, and she gets it once a year, and she calls in, and we can either just say, look, let's just treat it. We don't have to bring them in if she's sure she's got it, and if it's not that frequent. But if it's more frequent, we can just bring her in and do a urinalysis and then have her leave. The fact is that my office is pretty empty most of the time, and so we can do things
pretty quickly
without making people wait.
Yeah.
And so we can do things at people's convenience, and that really has enabled us to decrease the amount of office visits in the office. I used to average between 25 and 30 office visits per day in my old practice. Now, at most, pre-COVID-19, I was seeing between 8 and 12 patients on average, and at most, I don't think I've ever seen more than 15 patients in a day.
Holy cow.
So
So
it's
I'm
a big
assuming
difference.
part of that trade-off is you're spending more time with them, right?
Yeah. New patients, I spend an hour with a new
wow.
patient in the office, and half an hour for all the other visits. Half an hour is allotted. I mean, if somebody just has an ear infection or a strep throat, then it will take me 5 minutes, but it allows me to spend that extra time and ask extra questions and just to listen, and that works really well.
Yeah, I think you've hit on a lot of those topics, like this whole productivity or metrics driven healthcare being kind of a big giant soul crushing machine, right?
Right.
And you've kind of just stepped out of that. How does that work as far as, let's say, Susie Smith does have a UTI and she needs medicine or she needs an antibiotic or something like that. Does she still require some kind of insurance? You said they're not canceling. So how does that carry over? Let's say you're not in network, you're not accepting their insurance. Will an insurance provider still pay for the prescription?
Well, first off, for an antibiotic, antibiotics are real cheap.
Uh-huh.
And one of the things our office does is we actually also dispense medications, meaning
Okay.
we act like the pharmacy for patients. And so for our patients, if they need Bactrim or Cipro from us for a UTI, it's $2. You can get it from us for $2, or a
or run it through
Z-Pak for a
insurance and
strep
have like
throat.
a $20 copay, right?
Exactly. Or like blood pressure medicine, we can do for 75 cents a month or $1 a month. And the fact is that I'm financially motivated to do that, to keep the price as low as I possibly can. And the reason for that, and I tell patients directly, I'm not trying to hide things. My goal is to make things so ridiculously cheap as far as medications or lab tests. I can do a blood chemistry test for $4. I can do a a CBC for about $4, thyroid test for $8. All of those things I got the price as low as I possibly can. And so then what happens is my business model depends entirely upon the monthly fee. And if I make it so that the patients can't afford to not pay me every month, that's the secret sauce. I keep things cheap. I am, convenient in terms of people being able to get an appointment on the same day. There's very few days where my schedule is full ahead of time, even in the busiest of times. And so that allows me to take care of people very rapidly and get things. So convenience, responsiveness, low price, and predictable price. And so, but to answer the question you're saying is, what happens if they have an expensive medicine that I got to send off to the pharmacy and such? And the insurance companies do cover it. There's very few insurance companies that require the physician to be on the panel for them to be able to prescribe or do a referral. So if somebody needs to see a specialist, we can do that. We can get prior authorizations. Again, unfortunately, a lot of the bureaucracy that goes with healthcare is not eliminated from our standpoint, but we're no longer. I mean, that's all part of the monthly fee, so we're actually getting paid to do that. And so, and the only other thing is, let's say there's an expensive medicine. Somebody has psoriasis, and there's these $1,000 drugs that you can do,
Yeah.
or rheumatoid arthritis. How do you do that? Well, we have one of my nurses specializes really in um, getting medication for free from the drug companies. If the person's
Oh,
income
wow.
is below a certain level, you can get it for free from, and it doesn't take the poverty level. It's like $60 to $80,000 per year
Oh, so you
income
could still be making a
for,
decent income.
and you can still get free medicine. But we just have to fill out the paperwork and take care of it that way. And yeah, it works out.
Yeah, and because part of it is you're getting paid monthly no matter what, you can spend, staff resources and time on those quote unquote non-billable
Yep,
billable activities, right?
absolutely.
Yeah. So let's circle back then a little bit just to the whole idea of productivity based healthcare and metrics based healthcare. I think you've done some writing or some thinking about it because you're in direct primary
Mhm.
care now. But how do you see the incentive structure in traditional based healthcare, where you're billing insurance and you're kind of in that world? And how does that compare to kind of what you've described, where you're almost financially incentivized to make it super, super cheap so people will stay with you?
Right. Um, yeah, I would say there are two things, and this is, it's really the truth, that as a doctor, I was in the past, I was really being forced to choose between giving high quality healthcare, which means spending time with the patient, listening, um, not, taking care of problems early before they become big problems, handling problems without forcing people to come into the office, those types of things. That if I did all of that, that was for the patient's best interest, I was rewarded by not getting paid as much. I
Yeah.
was rewarded by having a lower salary, and essentially, I was forced as a doctor to choose between what's best for the patient and what's best for my business. And it sounds like, well, you should be selfish. You shouldn't be so selfish. I mean, let's put it this way. I had to choose between paying for my kids' college fund, or saving for retirement. And I mean, primary care is not that well reimbursed of a field in general. I mean,
Exactly.
primary care
Yeah.
doctors are not under the poverty level, but they're not like paid like cardiologists or orthopedic surgeons or ophthalmologists. We're the kind of the lower end as far as doctors are concerned, and so you really did struggle financially if you didn't run the mill and run patients through it and keep your waiting room full and make people wait. This has flipped it around, that I'm paid the same if my office is empty that if my office is full. And so I'm motivated to handle problems effectively and efficiently, to keep people away from the office, which means that if they're healthy and they're happy with the service they're getting, that's the ideal. And then they're going to continue to pay me on a monthly basis. And then when I'm needed, then they can reach out to me and get the care that they need. So this is, I mean, the motivations are in the old style of medicine, in the fee for service world. The motivations are against what the motivations of the patients are, what the desires of my patients were.
Yeah.
Now it's aligned exactly, that I'm again, to save money, to save time, to be effective, to be efficient, to spend time with people when they need to have time spent with them, to be responsive. All of those things are things that I am rewarded for. And I will say, financially, I'm in a better situation than I was when I was in my old practice.
Oh, really?
Yeah, and I'm
Nice.
still, and I've got about 800 patients, actually a little over 800 patients right now. And the rate at which people leave the practice is extremely low. It's about 1% per month,
Oh,
which
wow.
is,
Yeah.
yeah.
Well, and I'm sure part of that is because of their just general experience with it, right? Like they have increased access
Yeah.
to you. They're not waiting as long. They feel like they're getting heard and listened to.
Hmm.
Yeah, that's incredible.
Yeah, they're not used to getting a bargain, and not,
In
and
healthcare.
they're not. Yeah, in healthcare, they're not used to walking out of there feeling they got listened to and they got their needs met. And yet, we're motivated to do all of those types of things to make people go, "Huh, wow." We like to say that we used to say "I'm sorry" a lot, in healthcare. I'm sorry that I made you wait. I'm sorry for all this stuff. Now it's constantly "you're welcome." We're always telling people, they're so grateful, and they come in the first time and they're looking around and they're like, "Okay, what's the catch?" I said, "The catch is that you pay us every month.
Yeah.
That's it, and we tell you the catch ahead of time, so and you can predict your cost." And the ideal is to pair a direct care practice with a high deductible health plan, so that your insurance can be less. You don't need all the, and then you have somebody looking after your health to try and keep you from spending your deductible, and then maybe have an HSA account in the middle. That's to me the perfect storm for healthcare.
Yeah. So from just a logistical standpoint, your fees, do those count towards deductibles often or not? That's
No,
kind of outside of
no,
the purview.
it's totally outside of that. In fact, until recently, you couldn't even use your HSA cards, or you weren't supposed to use your HSA card. Some people still did that for our services. I it was just one of those strange healthcare rules. I think
Yeah.
it's because there was
Welcome
some
lobbyists, right?
there was some confusion as to whether or not we were offering insurance.
Oh, I see.
And so one of the early on concerns, and I started 7.5 years ago, so there were a lot more legal concerns then than there are now, because as opposed to about 100 practices when I started. In fact, less than 100 practices when I started. Now there's probably about 1,500 in the U.S. There's a lot of practices, and they're coming up all over at this point in time. So, but so the legal precedent has really been set in most states where direct care is no longer even confused with an insurance thing. So they've kind of put that away. But again, some people are like, well, I got insurance, so I'm gonna go see
Someone in
um,
network, right?
somebody in network, and it's like, okay, see you later. And I will see them later, because they're going to go back and realize that just because you get insurance doesn't mean you need to get bad health care. It's like, okay, so I'm going to wait in the waiting room, and I'm going to spend 5 minutes with the doctor, and I'm only going to tell them one problem at a time, and all of these types of things. And
And then I'm going to get a surprise bill a month later for, a couple $100.
yeah, right. There are no surprises in our practice.
Yeah. Have you had any experience dealing with folks like, my family and I are like on a health share plan because we're
Mhm.
self-employed and that's what we do. Does that interface well with something like a direct primary care service where the patient is already kind of used to paying out of pocket a little bit
Yeah,
for their services,
yeah. In fact, there are a number of health share plans that will give you a discount if you use a direct care doctor.
Oh, I see.
Yeah. There's Liberty, was one. Sedera is another one. There's a number of the health shares which are basically co-ops, and they're um, it's an ideal pairing, actually, because it's keeping the cost down, and the health shares realize that direct care, we tend to underutilize. We want to keep people out of the hospital, we want to keep people away from specialists, we want to do those types of things, and we have the time to do that, because we're not overwhelmed with how busy things are. So
Yeah, you don't have the volume and you're also, like you said, kind of incentivized to keep it down.
yeah.
from an access to you, or maybe even just the kind of the philosophy of care, it almost sounds like you're almost moving away, or maybe you already in your mind have already done that, moving away from like a reactive form of care
Right.
to maybe even a model that allows more health promotion and
Oh
wellness,
yeah.
right?
Oh,
You have a lot
absolutely.
of your patients that are really, or clients at this point, that are they're not sick when they see you or they reach out to you. It's more like, I'm thinking about this, or maybe trying to make this change in my life, this healthy
Sure.
lifestyle change or something.
Absolutely. Absolutely. And I just had a patient who has liver disease who said, "Can I," just sent me a text message, "Can I take this and this supplement?" And she would never be able to reach out to her doctor in the other practice, so she'd have to set up an appointment. She just sends a text message, and I answer it. That's it. Um, yeah, there's a lot of stuff that if people feel like, well, let me back up. When I was first doing this, I was trying to think through the whole business model, and I had read some books and talking about minimum viable products. What is the minimum viable what are
Yeah.
people actually buying when they come to see me? And so I just was trying to think through, because there was so much that I wanted to do, and I was just trying to figure it out. Because honestly, when I was doing it, there weren't a lot of other people to base my model on, so I kind of had to make it up. And there was a lot that I had these dreams of care. And what I realized is the thing that people want more than anything from their doctor is access. They want to have access to the doctor. They want to have when they need it. They want to have access to the nursing staff. They want to be able to come and get seen when they need to be seen. They want access, and that's really what we do. And our logo is an open door, and that's why. It's because it's like, yeah, it's not stay away, stay away, stay away, or you can only come in, you have to come in, but you're gonna have to wait
Yeah.
forever, and
Yeah. We've
you
got
can't
an
answer
appointment in 3
ask
weeks.
yeah, or you can't ask too many questions. We're just basically like, okay, what do you need? Anything else? That happens a lot where you're just like, is there anything else you need? Is there any other problem? And they're just not used to hearing that, where somebody is actually taking the time, and it's because I've got the time.
Yeah. Well, and it does kind of speak to that point, like what do people really buy, or what do they want from their healthcare providers? There's a lot of literature out there on the interwebs and through peer-reviewed published research at this point that kind of validates that and says, regardless of clinical skills and clinical abilities, I mean, obviously clinical competence needs to be the baseline. We're not
Right.
paying for people to be lower than clinically competent. But once you're competent, all the research indicates that what people value in their healthcare is that just the access, and then the interpersonal skills of their clinician, right? Like, you want to be able to talk to your doctor and feel like they're hearing you and listening to you and empathetic and all
That's
that.
huge. Listening is a skill that in healthcare has unfortunately gone away. And I get frustrated because I hear people say, you're really the first doctor who's ever really listened to me. And it's like, that's like saying you're the first chef that ever cooked food for me. It seems to me that if it's kind of in our job description to sit down and listen to what our people are saying to us, and yet people don't feel listened to by their doctors, because their doctors are busy looking at the medical record. They're busy looking at
Yeah.
the all of the stuff that they should have been. Anyway, it's just
Yeah.
all
Or
of this. They're
they're listening for specific things, right? Like, you come in for chest pain or shoulder pain or something like that, and they've got a specific thing that they're listening for, so they can figure out what to code, right?
Yeah, yeah. It's all about coding. It's all about billing. It's all about checking the boxes. And again, with the COVID-19 stuff, we were able to shift on a dime, and do way more virtual care. And so as the volume dropped down, our income didn't drop at all. In fact, far fewer people were canceling. Not people would. They're not going to say, "Well, gosh, during a health crisis is not. It's really not the best time to stop having access to the doctor anytime I
Exactly.
need him.
Yeah.
And so we saw almost no patients during the first month of the pandemic. That we saw almost no patients leave the practice, and we're able to do video visits and phone call visits, and and then occasionally have people coming in our office, but it didn't hurt us financially like it is a lot of practices, and it didn't really change the way that we were doing things all that much. It actually was kind of a continuation of the same. I just focused a lot more on education, explaining to writing stuff that my patients could read, that talked about COVID-19 and what to expect, and what does it mean to wear a mask, and what's the benefit
Yeah.
of that, and what things can
When
you
to wear
do.
them, when not to wear them, all that kind of
Yeah,
stuff.
yeah,
Yeah. Well, and you have the time because you're getting paid no matter what, right?
exactly.
To put out some of that, for lack of a better word, a public service message or public service content for your folks.
Absolutely.
And I know from me seeing your interactions online and seeing what you're posting, like I'm not even one of your patients and I'm getting the benefit of it, right?
Right.
Like how
Right.
much different would the world be if every doctor had the ability to kind of sit down and crank out a 15-minute read or something like that, a 5-minute
Right.
read on the current public health issues that they're facing or in their specialty. That's awesome.
Right. And honestly, that's called marketing on my part. I make it available to everybody because, gosh, people are far more likely to join my practice if they realize that I'm willing to give information and just say, look, I don't care. It's just share good information with people. And then they're like, this is not normal healthcare. The answer is, yeah, it should be.
Yeah.
But it isn't, because people don't. One of the things that I said from the very start is that people don't clamor for better health care enough. And the reason they don't is because they don't realize how bad the care that they're getting is. And the reason they don't know how bad the care that they're getting is because they don't know how good the care could be. And they
Oh
just
yeah.
have these low expectations of care. It's normal to wait an hour. No, that's wrong. It's normal to not get an appointment on the same day. That if you call in the morning with a sore throat, you're going to have to wait a lot longer, or they'll have to work you in. In our office, it's like, okay, can you stop by at 10, and we'll just do a quick strep test on you? And they're like, yeah, okay, well, we'll see you then. That's when they call first thing in the morning and have a sore throat. Sometimes we don't even, and then if I need to see them, I'll just pop in and see them. But I mean, I don't, the average wait time is still well under 15 minutes. It's probably 5 to 10 minutes at the most.
I was about to say, and that in and of itself is pretty incredible for a primary care physician.
Yeah.
Yeah. And I think how much so you kind of mentioned this, I kind of want to hit on this a little bit. How much of your initial startup, or even that you field now, questions, concerns, just misunderstandings from the public? Because like you said, even to take something like my example and going into health share, and people are talking to me like, oh my gosh, you don't have insurance? Like, what are you going to do?
Yeah.
Like there's this big, huge misunderstanding, or this fear almost of like, I don't have insurance, and that, we can't get health care. And it's even, driving some of the national, we're not going to get into politics, but some of the national debate and dialogue about what is healthcare and what do we mean by access to healthcare and all that. A lot of people kind of lump it in with insurance. So do you find yourself having to do a lot of education to your patients or potential patients, or do the ones that come to you have already kind of just opted, forget this, I'm
Now
trying to
it's a
figure
lot
something
less.
else?
Hang on a quick second. My Roomba decided to turn on right now. Hang on.
Oh.
All right, let's do this. There you go.
Gotta have those clean rooms, right?
It's nice to have. I don't have to. At first, it was all education. People were like, "Well, so I don't need insurance." No, you do still need insurance. Again, it's just this education as to what primary care, the role of primary care is, and the idea for me has always been, let's serve as a defense against the rest of the healthcare system of overuse of specialists, of overuse of emergency rooms or urgent care, where way too many things are being done. You come in with a cough and you immediately get a chest x-ray. Why? Because it raises the revenue of the business. That's the reason they do all those tests, and most of it's not necessary. And I will boil it down to the very necessary tests, and I won't underutilize, because if I hurt my patients, well, that's not very good.
Yeah.
People don't want to feel like they're getting suboptimal care, and they're paying me directly. And so I'm accountable to them, not to the insurance company, and such. And so the re-education is a lot less. And part of that too is just the word of mouth from people nowadays. I mean, I don't have to market at all anymore, because I've got 800 current patients, and I got tons of past patients who moved out, or anyway, they, for whatever reason, they're not seeing me anymore, but they're telling everybody to go see me, because oh yeah, it's
Well,
just
that's a
so
statement
good.
even of itself, that your
Oh yeah.
ex-patients are still telling people go see them.
Yeah, there's it's funny, because you look online, my online reviews are fun, because they're all positive. The only negative one was a guy who I didn't give narcotics to.
Yeah.
Yeah, he was like, it's unfair. He gave pain medicines to so-and-so and not to me, and I, whatever. It's like, yeah, well, totally different circumstance, but it doesn't matter. That's almost to me, the one negative one that I got was actually turned out to be a positive from my standpoint. It's like, yeah, I'll take it.
Yeah.
But yeah,
you mean I wasn't
overwhelmingly.
Okay.
I mean, it's the affection that I get from my patients, the loyalty. Back when I was like the third year I was in practice, one of the local MRI places had a best doctor contest, and they did it just on Facebook, voting on Facebook, and I put it up on my Facebook page, and my patients just stuffed the ballot box. It was like I got 60 votes and other doctors got 2. It was crazy. But they're almost evangelical about telling everybody, how much better it is to be in a direct care practice. And mind you, there are 2 other direct care practices in town that I'm actually affiliated with.
You're kind of helping plant the seeds all over the place, right?
Yeah. My practice is actually pretty full. I don't need to grow that much. And so Ed Boland actually is a family doc who came in, and he's actually working out of my office. He's actually has a separate business for now. We'll probably eventually merge practices, but both of us have gone through partnerships that were stressful, so we're both being cautious. And so, but Ed is growing his practice and doing really well, and then Davis, Melick, and Rachel are both some PAs, and they're out.
I've met them.
And they
are great people.
They are so sharp, and they're such good providers. They're such good. In fact, Ed and I say, yeah, they're definitely smarter than we are. They really are. They are incredibly sharp and very thorough. And I send my kids to them, actually. I fully trust their care. So we have options around the city for folks. My practice right now, I'm really limiting the number of new patients that I have, because first off, I don't want to grow so much that I'm not able to give the quality of care. And the second is that I want to be able to say, hey, but there is Dr. Boland, and there
are other people in the area.
Evans Direct Care. So I want to feed their practices, because we want this idea to grow.
Yeah, no, I think because, we've been kind of talking about it this whole time, like the incentive structure is different. Even like the whole piece about insurance, like if you think about what insurance was when it first came out, was not, like you said, putting gas in your car. It's for when your car gets T-boned running through a stop sign or something like that. So this idea of being able to utilize the insurance for what it's supposed to be, which is those catastrophic events, and then using out-of-pocket payment to get the regular everyday kind of care that, like you said, isn't that expensive, especially at what, $35, $60 a month or something like that, is
Right.
pretty incredible.
Right.
Have you heard of, outside of like primary care, have you heard of any other organizations or disciplines, even like ancillary healthcare providers, moving into this kind of space?
Um, yes, I've heard of it. One of the reasons that we want to grow direct care is, if let's say we had 5 practices or 10 doctors in the Augusta area, well, then we could basically keep a physical therapist, occupational therapist. We could keep specialists busy, and we could be giving, under that blanket. We could be have a gym, or have other types of things available. Have a dietitian. And there's all sorts of things that we could do. And then the question is, what about subspecialties? Well, the pure procedural subspecialties, like surgery, or
Yeah,
those types of things, that might not work.
that's a little bit unattainable
But
at this point, right?
something like dermatology, something like neurology, rheumatology, endocrinology, those things are much less. Those are much more, and certainly counselors.
Yeah, mental
There's a
health
lot.
providers.
Yeah, to be able to pull in mental health as part of the overall practice. That, to me, is one of those things that I'd love to see down the road, because then you're able to offer, under the auspices, under the umbrella of your monthly fee, you're able to offer a lot more care. And again, truthfully, a lot of what I do is amateur psychiatry. Well, it would be, really nice to be able to pull in a counselor to be able to help these people, so that, those anxiety-driven problems I'm not having to manage as much. And then I have the chance to grow the practice even more, because we have good care. We've talked about pulling in X-ray, or pulling in, ultrasound, or there's a lot of folks doing those types of things across the country, and
Yeah,
so
like
the
private
movement
imaging
is.
centers and that sort of thing.
Yeah, and lastly, one of the things that is, again, part of the thought process is, what if there's some surgery centers around the country. They're starting to pop up. The closest one is in Charlotte, but the famous one is in Oklahoma City. These are surgery centers that are basically cash only. They are able to do a gallbladder surgery at a quarter of the cost, because really the overhead of having the hospital involved, of having
Yeah,
all
compliance
insurance
and
companies involved,
administration.
having all of those types of things. But if you pay cash for it directly, then the overall cost goes way, way down, and you're able to really do it for about a quarter of the cost that you would normally do. And so, with the health shares, some of the health shares even
Yeah.
direct people towards these types of things. One of them, we were talking to another group that was doing direct care, but it was a larger organization that was kind of directing direct primary care. And one of the things they were able to do is fly some patients down to Aruba to get a prescription for some of these really,
Oh, wow.
$10,000 a month medicines, and they can get them for like $200 in Aruba, and so they can put them up in a 4-star, 5-star place, and then have them get 3 months of medicine, and then fly back, and they save thousands and thousands of dollars that way. It was just so funny,
Yeah,
all these
a
different
vacation
things.
and your health. Yeah.
Yeah, and so they're able to. But the nice thing is, once you pull the insurance rules, and especially once you pull Medicare out of it, you can there are no rules that you have to follow. You just need to give good care, and that's the thing, is I
Yeah.
don't have to
Focused on the patient.
obey all those rules that say, no, you got to document this way, otherwise you don't get paid. You have to do all these things, otherwise, I'm answerable to the person who's sitting across from me. And that to me that's the ideal.
Yeah.
And I will say that I am so much happier doing it this way. And my patients are so much happier. My nurses are just so grateful that I'm doing it this way, that they're able to give better care, and it's just a better situation.
Yeah. Now you mentioned Medicare there. Is there, I know like with cash-based physical and occupational therapy clinics, there's this huge thing around, Medicare. You can't charge a Medicare patient cash for a service that Medicare already provides. Does primary care fit under that, or how do you address that with Medicare patients?
We have opted out of Medicare. So it doesn't,
Oh, okay.
I opted out of Medicare, and that was the very difficult decision to make. That do I, what do I do as far as when I opted out of Medicare? It felt scary. It felt freeing, but it felt scary. And so, in terms of yeah, if I was still listed under Medicare, if I was still able to bill for Medicare, then no, I could not accept the monthly fee. But as long as I've opted out, I'm fine.
Oh, okay. Well, that makes it easy then. Just opt
Yep.
out.
Yep.
All righty. Well, we're ready to wrap up here. Are there any last minute thoughts that you would have to share with our audience about just direct primary care in general and direct access to healthcare?
Yeah, I just think that people need to open their mind to other options. We get this idea that we have equated healthcare with insurance. And so we say this is a healthcare bill. The ACA was a healthcare bill. No, it wasn't. It was a health
It was an
insurance
insurance
bill,
bill, yeah.
and it had nothing to do with care. I mean, it had to do with payment of the care, the affordable, the access to care. It has to do with the unaffordability of the care. And so I think as we shift our mindset that says, okay, healthcare doesn't have to be that. And certainly this idea of primary care requiring insurance, that's something that needs to go. It really needs to go, because what you're doing is putting primary care doctors under the thumb of insurance companies, and or under the hospitals who employ
Yeah,
them.
who are buying
Um,
these primary care
who are
physicians?
yeah,
Right? Yeah.
and they have primary care physicians for one reason: to feed the hospital and feed the specialists. It's for revenue, revenue, revenue. It's all about money. And so if the primary care keeps people away from seeing the specialist, keeps people out of the hospital, then it's actually hurting the hospitals. And so they don't want you doing that. They would far rather you just refer everybody. And that's not the care anybody deserves. It's not the care that anybody wants. And so, I just think people resetting in their minds what healthcare should look like and being able to reimagine it. And it sounds too good to be true, and yet people say, well, how do you compare your life before doing this and now? It's like, well, before I was underwater, barely able to get to the surface and breathe a little bit and then sinking again. And now I'm sitting on the beach with a mimosa. And it's like there's no way I could ever go back to that care. And I'm doing so and making my patients happier. I'm earning a better income. I'm giving better care. There's really not that. There's no downside.
Yeah, it's a
to what I'm
no-brainer
doing.
choice, right?
Yeah, it really is.
All right. Well, Dr. Rob, thank you for sharing your time with us. If people want to follow up with you, kind of learn more about you, your practice, or direct primary care in general, where would you send them?
Well, if you do Facebook, my Facebook page is real active. I got a whole bunch. So just look at Dr. Rob Lamberts, Lamberts with an S at the end, or go to my website, which is Dr. Lamberts. It's DoctorLamberts.org. And just Google Dr. Rob Lamberts. You'll be able to find me.
All righty. Thank you very much, sir.
All right, Rafi. Thanks a lot.
Yeah. Well, that was Dr. Rob Lamberts, a direct primary care physician here in Augusta, where I'm located. Hopefully you found that interview insightful and pull some nuggets from it. I think the model of primary care, direct primary care like that, where there's a flat fee and you've basically access to your clinician, is something that works whether you're in primary care as a physician or whether you're in ancillary healthcare services like physical therapy or occupational therapy or speech language pathology or something like that. The idea of being able to offer basically open door access to a select number of clients just seems very appealing to me. You're taking the whole idea of productivity-based healthcare where metrics and numbers drive a lot of the decisions, and you're taking that away, like Dr. Rob said. He gets paid whether his patients are showing up and utilizing his services or not. And I think that just allows a little bit more freedom for him to spend more time with those patients, with those clients. He's also limiting the number of people he's allowing or clients that he's allowing in his practice. So again, there's that decreased volume aspect. So he's able to provide that one-on-one service. He's able to provide a little bit extra time, get down to the precipitating factors. If you're in the musculoskeletal or orthopedic world, you're likely familiar with that term. It doesn't do us any good to do manual therapy or to do joint mobilizations or address the symptoms that a client might be experiencing, let's say in chronic low back pain or shoulder pain, and not address those precipitating factors. Because what's going to happen is the patient's going to go, they're going to leave your clinic after you do those manipulations, after you do those treatments that are addressing kind of the symptoms, and they're going to feel great, and then they're going to leave, and the next day they're going to feel bad again, right? So by aligning his incentives, so to speak, in his business with basically the needs of the patient, he's able to spend that time and drill down into those precipitating factors with patients when they need it. And whether or not they use his services 5 times or whether they're using his services once, every other month, he's still getting paid. He's still able to provide the services to the clients who need them when they need them. And he's not pressured to get patients in, to run tests, to do all kinds of, quote unquote, get their units, their billable units for patients in his clinic. So it's a great model. If you're interested in doing that, I know there's a bunch of physical therapists and occupational therapists moving in that direction as well. If you happen to be in the rehab space and you want to look into that, it is definitely a possibility. With that being said, we will see you on the next episode. If you like what we're doing, head on over to iTunes, give us a rating and review. I'd love for you to subscribe and get these episodes on your device whenever we drop a new one. We drop them every 2 weeks. You can also go to our website, betteroutcomes.show, and sign up for the email list there, and we will send a transcript and the show post directly to your inbox. Until the next episode, be safe, be healthy. I will talk to you then.
Thanks for listening to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Our hope is that you walk away from each episode informed, equipped, and empowered to push the boundaries in your own practice or business. We want to give you the tools to help you build strong, long-lasting relationships with your patients and clients, helping meet their goals, improve their health, and achieve better outcomes. Learn more at www.rehabuppracticesolutions.com. We'll catch you on the next episode.